The Senate Committee on Health, Education, Labor, and Pensions will come to order. Chronic disease presents one of the greatest challenges to the public health of the American people. Research shows that almost 1 out of every 2 adults has at least one chronic disease. We also know that nearly 1/4 of individuals with chronic disease have 1 or more daily activity limitations. It's a staggering fact that 7 out of 10 deaths among Americans are related to chronic illnesses. Our nation's fiscal well-being is also impacted by chronic disease. Of the more than $2 trillion we spend on health care, 75% is accounted for by individuals with chronic conditions. In the workplace, these conditions account for nearly $1 trillion in lost productivity each year. Chronic disease is a huge cost to both private and public sectors and a major contributor to our deficits and our debt. A study by the Trust for America's Health, titled Prevention for a Healthier America, found that investing $10 per person in proven community-based programs to increase physical activity, improve nutrition, and prevent tobacco use could save the nation about $16 billion annually within 5 years. The Community Transformation Grant Program and the Affordable Care Act helps communities to implement evidence-based strategies that prevent the development of chronic diseases. Through this program, communities develop public-private partnerships and collaborate to tailor health promotion initiatives that meet the unique needs of their residents in addressing chronic disease. This helps turn the environment in which local residents live, work, play, and raise their families into one that provides a greater array of healthy choices, making the healthy choice the easy choice. I've often said, it's easier to be unhealthy and harder to be healthy. And shouldn't we turn that dynamic around? Shouldn't it be easier to be healthy and harder to be unhealthy? That's why the Prevention and Public Health Fund, which I authored in the Affordable Care Act, is so fundamental to addressing the gap that exists between what is and what can be done to address chronic illness. The Prevention Fund supports evidence-based health promotion programs. However, this fund is only a small down payment in comparison to the size of the problem. Some critics have called the fund a, quote, slush fund. Well, that's nonsense. Another tool in addressing chronic disease is the use of evidence-based clinical preventative services. We significantly increase the availability of these critical activities in the Affordable Care Act by requiring first dollar coverage of recommended preventative services. Many Americans are already benefiting from these important evidence-based preventative services and wellness visits, which will help lower costs, prevent disease, and save lives. These services also make great economic sense. For example, for every $1 we spend on the full course of childhood vaccines, we save $16.50 in future health care costs. In the past, so many times we set up goals, and we never seem to achieve them. We set this little goal and that little goal and this little goal. I think what we try to do in the Prevention Fund and in the Affordable Care Act was to set up not so much a goal here and there, but to set up a dynamic, a system, whereby there would be, as Dr. Coe said, this interrelationship between the clinical services, the community-based services, the workplace-based services, the school-based services that would all kind of be working together in a dynamic to sort of change the inputs into health care. So that over a period of time you just have a different structure. You have a different systems approach. Mm-hmm. Rather than saying, well, we're going to work with everything we have, but we're going to have a goal. Well, if you work with everything you have and you have a goal, you're never going to get the goal because the systems don't work. We have to change the systems. So I would just say that, but I agree that we do need goals out there again, but still we need to change the system and not just have a goal for an unworkable system that we have now. I say to my friend.
We do want an overarching integration of all of the approaches that are being taken in the Affordable Care Act, because there are those of us who believe that this will save us tremendous amounts of money over the years, and that we need to demonstrate that in a way that's convincing and a way that's real.
You say, well, the answers aren't easy. You say prevention first is a long-term commitment policy. Long-term. And most of us around here are interested in short-term fixes. And but that's true of human nature. People want to be able to live their lives however they want to live, and I want that pill. I want that magic pill that will make it all right. Clean me all up again and start me over again. all that kind of stuff. So it's kind of human nature. That's why we look for systems approaches, and that's why I keep emphasizing that we need it early on. It's got to be broad-based, early on, childhood, preschool settings, neighborhoods, communities, schools, certainly in the homes, but also in the workplace. And that's one place where I have found in the past some private sector employers have been way ahead of the curve on this. I have examples that go back 25 years of employers in my state that decided to put in wellness programs in their plants, prevention, cut down on smoking. They gave incentives to workers, benefits, some of them pretty nice benefits, if they would see an in-house nutritionist, dietitian, something like that, and cut down on smoking. And what we found was that in these early days that their productivity shot up. See, you always look at the cost, but their productivity went up, turnover rates went down, absenteeism went down, workers would stay overtime just to make sure everything was right. Nobody was rushing to the door. We know these things work, but why aren't more employers doing it? People of low income tend to have bad diets. Now, why do people of low income have bad diets? Well, as Michael Pollan pointed out in his book, he began to think about that. And he went in the grocery store and found out that poor people buy, with food stamps, SNAP program and others, they tend to buy foods that are high in sugars, fats, sugar, fat, and sodium. Sugars, fats, and starches. I'm sorry, sugars, fats, and starches. Why do they do that? Because they're the cheapest. Why are they the cheapest? Because we subsidize those the most in agriculture. Not fruits and vegetables. We don't subsidize those, but we subsidize starches, fats, and sugars. So they're cheap. So people go and buy them. If you're pinching pennies, you don't go to the fresh fruit and the fresh produce counter. You buy packaged products that are very cheap. High in sodium, too, by the way. Very high in sodium. So it seems to me that, that we're trying some things. We tried some things in the last Farm Bill to try to get more fresh fruits, fresh vegetables to those food deserts, as they say, in the inner cities and things. But again, it seems to me that this is a public health problem.
No question.
It's a public health problem. And why shouldn't we be approaching it that way? I appreciate you saying it. That was the thought processes and the discussion that went on in setting up these community transformation grants. Not that the government has all the answers, we don't, but providing some framework for communities to get together and discover their own ways of doing things and coming. A lot of times people say, well, what you're talking about is common sense. Well, yeah, it's common sense, but until you get people together in groups and have these supporting elements in communities where they recognize it's a community problem, common sense kind of goes out the window. Because people are sort of out there just on themselves out there and they don't know what they need to do. But with the community transformation grants, you encourage them to come up with their own solutions.
That's right, but outcome-based. We want, at the end of it, like the programs that the Y is doing.
Well, I want an outcome-based, and I want to know which ones work best.
Right, exactly.
So I diverge a little bit from some of my colleagues who said we don't want to put money in anything that's not proven. Well, I'd like to test some theories out. I'd like to see maybe somebody's got some ideas. Some communities have an idea out there on doing something that hasn't been done before. Okay, let's see if it works. Maybe somebody's got a better idea out there. And why should we be constrained by just the narrow things of what we know that works? Maybe there's other things out there that will be that'll work. So that's why I've been very promotive of getting communities to come up with new ideas and new approaches on this.